I'm a cardiologist at Riverside Heart Center in Nashville, Tennessee, or at least I was, until I submitted my resignation 9 months ago. You can call me Dr. Samuel Hayes if you want, though most people in the cardiac intensive care unit just called me the Heart Whisperer during my 24 years there. I've seen everything you can imagine in cardiology: catastrophic heart attacks, complex valve surgeries, devastating cardiomyopathies, and every kind of damage the human heart can endure. But what I'm about to tell you about is the one case that made me question everything I thought I knew about cardiac death, and ultimately led me to leave the profession entirely. Riverside Heart Center is a premier cardiovascular hospital serving Middle Tennessee and Southern Kentucky. It's a comprehensive cardiac facility with one of the most advanced heart transplant programs in the Southeast, and a cardiac intensive care unit that handles some of the most complex cases in the region. During my time there, I consulted on thousands of critical cardiac cases, performed hundreds of catheterizations, and worked with families facing impossible decisions about life and death when the heart fails catastrophically. The case I'm about to tell you about began long before I met the patient. It started on a crisp autumn morning, October 22nd, 2018, in the historic town of Franklin, Tennessee, about 20 miles south of Nashville. Isabella "Izzy" Thompson was 38 years old, a professional dance instructor and former competitive ballroom dancer who had never experienced so much as chest discomfort in her entire life. Izzy owned a successful dance studio called Rhythm and Soul in downtown Franklin, where she taught everything from wedding dance lessons to advanced competitive ballroom. She was known throughout the community for her boundless energy, infectious enthusiasm, and the way she could transform even the most awkward beginners into confident dancers. That Tuesday morning, she was preparing for what should have been just another routine day at her studio. October 22nd started like thousands of other mornings in Izzy's life. She arrived at her studio at 6:30 a.m., an hour before her first class, to review choreography and set up the sound system. The autumn air was crisp and clear, with golden leaves scattered across the sidewalks of Franklin's charming downtown district. Izzy had opened her studio 6 years earlier, after retiring from competitive dancing due to a minor knee injury. At 32, she had decided to channel her passion for dance into teaching, and her studio had become one of the most popular dance schools in Middle Tennessee. Her students ranged from nervous wedding couples to serious competitive dancers, and she was known for her patience, creativity, and ability to bring out the best in everyone who walked through her doors. That Tuesday morning, Izzy was preparing for her 7:30 a.m. advanced Latin dance class. A group of 8 dedicated students who had been training with her for over 2 years. She was reviewing a new salsa routine she had choreographed for an upcoming showcase when it happened. At exactly 7:03 a.m., while reaching up to adjust the studio's mirror lighting, Isabella Thompson collapsed without any warning whatsoever. There had been no chest pain, no shortness of breath, no dizziness, no symptoms of any kind. One moment she was gracefully adjusting the lights, humming along to the music playing softly in the background. The next moment, she was on the polished wooden floor of her dance studio, unconscious and not breathing. Fortunately for Izzy, her first student of the day, Margaret Kellum, had arrived early, as she often did. Margaret was a 45-year-old registered nurse who worked in the cardiac unit at Williamson Medical Center and had been taking dance lessons with Izzy for 3 years. She had come in 15 minutes early to stretch and warm up before the advanced class. Margaret later described entering the studio and immediately knowing something was catastrophically wrong. Izzy was lying motionless on the floor in an unnatural position, her face already showing the grayish pallor that Margaret recognized from her years of cardiac nursing. Without hesitation, Margaret checked for a pulse and found none. Izzy wasn't breathing, and her skin was already becoming cool to the touch. Margaret immediately began CPR, while simultaneously calling 911 on her cell phone. 911, what's your emergency? This is Margaret Kellum. I'm a registered nurse at a dance studio at 315 Main Street in Franklin. I have a 38-year-old female in full cardiac arrest. I'm performing CPR now, but I need an ambulance immediately. Ma'am, is she breathing at all? No breathing, no pulse. She appears to have suffered sudden cardiac death. I've been doing compressions for about 2 minutes now. Margaret continued CPR for what felt like an eternity, but was actually 8 minutes until the Franklin Fire Department paramedics arrived. During those 8 crucial minutes, she never detected any sign of life. No pulse, no spontaneous breathing, no response to the chest compressions that she delivered with the precision of her nursing training. The Franklin Fire Department Emergency Medical Services arrived at 7:16 a.m., 13 minutes after Izzy's collapse. Paramedic Captain James Rodriguez and EMT Sarah Mitchell found a 38-year-old female in complete cardiac arrest, with a nurse performing high-quality CPR. Captain Rodriguez immediately took over chest compressions, while EMT Mitchell prepared the cardiac monitor and defibrillator. When they attached the monitor leads to Izzy's chest, the screen showed ventricular fibrillation, a chaotic deadly heart rhythm, where the heart muscle quivers uselessly instead of pumping blood. V-fib on the monitor, Captain Rodriguez announced, charging to 200 joules. They delivered the first electric shock to Izzy's heart at 7:18 a.m. The monitor briefly showed a normal rhythm for 3 beats, then returned to ventricular fibrillation. Still in V-fib, resumed compressions, charged to 200 again. The second shock was delivered at 7:20 a.m., followed immediately by the administration of epinephrine and amiodarone, powerful cardiac medications used in resuscitation attempts. The monitor continued to show ventricular fibrillation despite the shocks and medications. During the 22-minute transport to Williamson Medical Center, the paramedics delivered a total of 4 electric shocks to Izzy's heart and administered 3 rounds of advanced cardiac life support medications. Throughout the entire transport, they were unable to restore a sustainable heart rhythm or detect any signs of spontaneous circulation. By the time they arrived at the hospital emergency department, Isabella Thompson had been in cardiac arrest for 31 minutes. Dr. Patricia Wong, the emergency physician on duty that Tuesday morning, met the paramedics at the ambulance bay. She had been alerted by radio that they were bringing in a young woman in refractory cardiac arrest, meaning a cardiac arrest that wasn't responding to standard resuscitation efforts. "What do we have?" Dr. Wong asked as they wheeled Izzy into trauma bay. 38-year-old female witnessed cardiac arrest at approximately 7:03 this morning, Captain Rodriguez reported, while continuing chest compressions. Bystander CPR was started immediately by a nurse. "We've given 4 shocks, 3 rounds of EPI, amiodarone, and she's been down for 31 minutes. Persistent V-fib throughout." Dr. Wong took one look at the cardiac monitor and knew they were facing a critical situation. 31 minutes of cardiac arrest with persistent ventricular fibrillation was approaching the limits of survivability, even with perfect resuscitation efforts. "Let's try once more," she said. "Charge to 360, everyone clear." The 5th electric shock was delivered at 7:36 a.m. For a brief moment, the monitor showed what appeared to be a weak but organized heart rhythm. Then, unexpectedly, they detected a faint pulse. "I've got a pulse," announced Dr. Melissa Carter, the emergency resident, who was checking Izzy's carotid artery. "It's weak, maybe 40 beats per minute, but it's there." The room erupted in controlled excitement. After 33 minutes of cardiac arrest, Isabella Thompson's heart had finally responded to resuscitation efforts. But Dr. Wong knew that this was just the beginning of what would likely be a very complicated medical situation. With a weak pulse restored, the emergency team quickly moved to assess the extent of damage that Izzy had sustained during her prolonged cardiac arrest. An emergency bedside echocardiogram, an ultrasound of the heart, revealed devastating news. Izzy's heart was barely contracting. Her left ventricular ejection fraction, which measures how much blood the heart pumps out with each beat, was estimated at less than 15%. A normal ejection fraction is 55 to 65%. Izzy's heart was pumping less than a quarter of the blood it should have been pumping. Her blood pressure, even with the restored pulse, was critically low at 70/40 mmHg. Her oxygen saturation was poor despite being on 100% oxygen through a breathing tube. Most concerning, she showed no neurological responses, no reaction to painful stimuli, no spontaneous eye movements, no response to verbal commands. Dr. Wong immediately started Isabella on high-dose vasopressor medications, powerful drugs that support blood pressure and heart function in critically ill patients. Even with maximum doses of norepinephrine and epinephrine, Izzy's blood pressure barely reached 80/50 mmHg. "We need to get her to a cardiac center immediately," Dr. Wong told the team. "This level of cardiac dysfunction is beyond what we can manage here." Williamson Medical Center, while an excellent community hospital, did not have the specialized cardiac intensive care unit or advanced cardiac support devices that Izzy would need. Dr. Wong made the decision to transfer her to Riverside Heart Center in Nashville, where the cardiac intensive care team would be better equipped to manage such severe heart failure. But there was a problem. Izzy was too unstable for a ground ambulance transfer. Her blood pressure was barely maintaining with maximum medications, and any interruption in her care could result in another cardiac arrest. She needed helicopter transport with a specialized critical care team. At 8:15 a.m., Life Flight was called to transport Isabella Thompson to Riverside Heart Center. The helicopter crew included Dr. Michael Stevens, a critical care physician, and Jennifer Walsh, a critical care paramedic specializing in cardiac emergencies. During the preparation for flight, Izzy's condition deteriorated further. Her blood pressure dropped to 60/35 mmHg despite maximum vasopressor support. Her heart rhythm became increasingly irregular, showing frequent dangerous arrhythmias that threatened to deteriorate back into cardiac arrest. "She's not going to make the flight if we don't get better cardiac support," Dr. Stevens told Dr. Wong. "We need to start an intra-aortic balloon pump before we move her." An intra-aortic balloon pump is a mechanical device that helps support the heart's pumping function by inflating and deflating a balloon inside the main artery, leaving the heart. It's typically used as a bridge to more definitive treatment in patients with severe heart failure. The procedure to insert the balloon pump took an additional 40 minutes, during which Izzy's condition remained critically unstable. Finally, at 9:20 a.m., she was loaded into the helicopter for the 15-minute flight to Nashville. I was in my office at Riverside Heart Center that Tuesday morning, reviewing cases for our weekly cardiac surgery conference, when my pager went off at 9:35 a.m. The message was brief but alarming. "Incoming Life Flight 38F, post-arrest cardiogenic shock, ETA 5 minutes, Dr. Hayes to CCU stat." Cardiogenic shock in a 38-year-old was extremely unusual. Most cardiac arrests in young previously healthy individuals are either due to congenital heart defects, drug overdoses, or extremely rare genetic conditions. As I hurried down to the cardiac intensive care unit, I was mentally preparing for what I expected to find is either a young woman with a previously undiagnosed congenital heart problem or someone whose cardiac arrest was secondary to some other medical emergency. What I found when Isabella Thompson arrived in our CCU was unlike anything I had encountered in my 24 years of cardiac medicine. The helicopter crew wheeled in a young woman who appeared to be in the most severe form of cardiogenic shock I had ever seen in a surviving patient. Despite maximum doses of 3 different vasopressor medications and mechanical support from the intra-aortic balloon pump, her blood pressure was 75/40 mmHg. Her heart rate was irregular, fluctuating between 35 and 95 beats per minute with frequent premature beats. Most concerning was her cardiac function. The portable echocardiogram from the helicopter showed global severe left ventricular dysfunction, meaning that essentially all of her heart muscle had been severely damaged during the cardiac arrest. Her ejection fraction was estimated at 10 to 12%, a level that is typically incompatible with survival. Dr. Hayes, Dr. Stevens briefed me as we transferred Izzy to our CCU bed. She was down for 33 minutes before we got spontaneous circulation back. She's been requiring maximum cardiac support since resuscitation. Her rhythm has been unstable throughout transport. I performed my initial examination while the nursing staff connected Izzy to our advanced cardiac monitoring systems. She was unconscious and unresponsive to any stimuli. Her pupils were fixed and dilated, a sign that typically indicates severe brain injury from prolonged lack of oxygen. Her breathing was being supported by a ventilator, and she showed no spontaneous respiratory effort. But it was her heart function that truly concerned me from a cardiac standpoint. Our advanced echocardiogram confirmed the devastating picture that had been seen in the field. Isabella's heart was barely contracting. The walls of her heart muscle moved sluggishly and ineffectively. The amount of cardiac damage suggested by her heart function was so extensive that I was frankly surprised she had survived the helicopter transport. Isabella's first day in our cardiac intensive care unit was a constant struggle to maintain basic life functions. Despite being on the maximum doses of 4 different cardiac medications, norepinephrine, epinephrine, milrinone, and vasopressin, her blood pressure remained precariously low. The intra-aortic balloon pump was working at full support, literally helping to pump blood through her body with every heartbeat. Her blood tests revealed the full extent of the damage that had been done during her cardiac arrest. Her troponin 8 level, a marker of heart muscle death, was 847 ng/ml. To put this in perspective, a normal troponin level is less than 0.01 ng/ml. A heart attack typically produces troponin levels of 5-50 ng/ml. Isabella's level suggested that a massive amount of her heart muscle had died, minus far more than should be compatible with survival. Her other organ systems were also showing signs of severe damage from the prolonged cardiac arrest. Her kidney function was deteriorating, with creatinine levels rising throughout the day. Her liver enzymes were elevated, indicating damage to her liver from lack of oxygen. Most concerning, her neurological status remained unchanged. She showed no signs of consciousness or meaningful brain function. That Tuesday evening, I had my first conversation with Isabella's family. Her husband, Marcus Thompson, had driven up from Franklin as soon as he received the call. Marcus was a 41-year-old architect who had met Izzy 12 years earlier when he took ballroom dancing lessons at her studio. They had been married for 8 years and had no children, though Izzy often said her dance students were like her children. Marcus was accompanied by Izzy's parents, Robert and Catherine Delacroix, who had driven in from Memphis, and her younger sister, Amelia, who lived in Nashville and worked as a physical therapist at Vanderbilt Medical Center. Dr. Hayes, Marcus said, his voice strained with exhaustion and worry. Please tell me honestly, is she going to make it? I had delivered difficult news to countless families over the years, but Isabella's case presented unique challenges. Her cardiac damage was so extensive that survival seemed unlikely, yet she had already survived longer than most patients with similar injuries. Marcus, I want to be completely honest with you about Isabella's condition, I said, choosing my words carefully. Her heart has sustained massive damage. The amount of heart muscle that appears to have been destroyed during her cardiac arrest is among the most severe I've encountered in a surviving patient. But she is surviving, Amelia interjected. Her heart is beating. It's beating because we're supporting it with very powerful medications and a mechanical device, I explained. Her natural heart function is extremely poor, less than 15% of normal. Most of the circulation in her body right now is being maintained artificially. Robert, Izzy's father, asked the question I had been expecting. What are her chances of recovery? I paused, looking at each family member before responding. Impatience with this degree of cardiac damage, especially after such a prolonged cardiac arrest. Meaningful recovery is extremely rare. The combination of severe heart damage and potential brain injury from oxygen deprivation makes her prognosis very poor. But there's still a chance, Marcus asked hopefully. There's always uncertainty in medicine, I replied carefully. But I want you to understand that Isabella is critically ill with injuries that are typically not survivable. We're doing everything medically possible, but you should prepare yourselves for the possibility that she may not recover. Over the next several days, as Isabella's condition remained critically unstable, I found myself increasingly puzzled by the circumstances of her cardiac arrest. In my 24 years of practice, I had learned that sudden cardiac death in young healthy individuals almost always has an identifiable cause. The most common causes of cardiac arrest in young adults include hypertrophic cardiomyopathy, a genetic condition that causes thickening of the heart; muscle arrhythmogenic right ventricular cardiomyopathy, a genetic condition affecting the heart's electrical system; long QT syndrome, an electrical abnormality that can cause dangerous arrhythmias; drug overdose or poisoning; acute myocardial infarction, heart attack due to coronary artery disease; pulmonary embolism, blood clot to the lungs. But Isabella didn't fit any of these typical patterns. Her family history was negative for any cardiac conditions. She had never used drugs or had any concerning symptoms. Her electrocardiogram, when she was stable enough for testing, showed no evidence of the genetic conditions that commonly cause sudden cardiac death in young people. On Thursday, October 24th, we performed a cardiac catheterization, a procedure where we thread a small camera through blood vessels to examine the coronary arteries that supply blood to the heart muscle. This test is essential for understanding whether a heart attack caused by blocked arteries was responsible for Isabella's cardiac arrest. The results were completely normal. Isabella's coronary arteries were perfect, no blockages, no narrowing, no evidence of any abnormality that could have caused a heart attack. For a 38-year-old who had suffered such massive cardiac damage, this finding was extraordinarily unusual. "I've never seen anything like this," commented Dr. Jennifer Martinez, our interventional cardiologist who performed the catheterization. "The amount of heart muscle damage we're seeing on her echo should correspond to massive coronary artery blockages, but her arteries are completely normal." We expanded our testing to look for other possible causes. Toxicology screens for drugs and poisons came back negative. Tests for viral infections that can cause heart muscle inflammation were negative. Genetic testing for inherited conditions that cause sudden cardiac death was sent out, but those results would take weeks to return. Isabella's cardiac arrest remained medically unexplained. As October turned into November, Isabella's condition settled into a critically unstable but consistent pattern. She remained unconscious and dependent on a ventilator for breathing. Her heart function showed no improvement despite every medication and intervention we could provide. The intra-aortic balloon pump continued to provide mechanical support for her circulation. Her family maintained a constant vigil in the cardiac intensive care unit. Marcus took leave from his architectural firm and essentially moved into the hospital. Izzy's parents alternated staying in Nashville to help support Marcus and returning to Memphis to manage their own lives. Amelia visited daily after her work at Vanderbilt. During this time, I began to notice something that challenged my initial assessment of Isabella's neurological condition. While she showed no response to standard neurological tests, no keen reaction to painful stimuli, no eye movement to commands, no purposeful movements, her family insisted they were seeing subtle responses that weren't captured in our medical examinations. When we play her favorite music, Marcus told me during one of our daily meetings, her heart rate changes. It's not random. It specifically changes when we play the songs she used to dance to. Amelia supported this observation. Yesterday, when I was telling her about her students, asking about her, her blood pressure went up. The nurse said it was probably just a coincidence, but it happened every time I mentioned specific students' names. I had seen this phenomenon many times before in families of critically ill patients. The desperate hope for signs of consciousness often led family members to interpret random physiological fluctuations as meaningful responses. Heart rate and blood pressure in critically ill patients change constantly due to medications, body position changes, and countless other factors that have nothing to do with consciousness or awareness. Marcus, I explained gently, it's completely natural to look for signs that Isabella can hear you and is responding, but in patients with severe brain injury, these changes in vital signs are usually not indicators of consciousness. They're more likely related to her medications or other physiological factors, but the family remained convinced that Isabella was somehow aware of their presence and their conversations. By November 12th, Isabella had been in our cardiac intensive care unit for 3 weeks. Her condition had not improved in any measurable way. Her heart function remained severely depressed, showing an ejection fraction that had improved only slightly to 18% mg, still far below the level needed for independent survival. Most concerning was her continued dependence on maximum cardiac support. Despite 3 weeks of treatment, we had been unable to reduce her cardiac medications or remove the intra-aortic balloon pump without her blood pressure dropping to dangerous levels. Her neurological status remained unchanged. She showed no signs of consciousness, no meaningful responses to stimuli, and no improvement in her neurological examinations. The extensive brain injury from her prolonged cardiac arrest appeared to be permanent. I began having serious conversations with her family about long-term care options and the realistic limitations of continued aggressive treatment. Marcus, I said during our meeting that Tuesday morning, Isabella has been critically ill for 3 weeks now. While she has survived longer than we initially expected, there has been no meaningful improvement in her heart function or neurological status. But she's stable, Marcus replied. She's not getting worse. She's stable only because we're providing maximum artificial support for her heart, I explained. Her natural heart function is still severely impaired, and she remains unconscious. After 3 weeks, the likelihood of significant recovery becomes very small. Catherine, Izzy's mother, asked the question that had been weighing on everyone's minds. Are you saying we should consider stopping treatment? It was one of the most difficult conversations I had ever had with a family. I'm not making that recommendation yet, I said carefully, but I think we need to start discussing what Isabella would have wanted in this situation. At some point, if there's no improvement, we may need to consider whether continued aggressive treatment is consistent with her values and wishes. The family was not ready to have that conversation. Marcus, in particular, remained convinced that Isabella would recover, given enough time. Dr. Hayes, he said, Izzy is the strongest person I've ever known. She's never given up on anything in her life. She wouldn't want us to give up on her now. On November 18th, exactly 4 weeks after Isabella's initial cardiac arrest, her condition took a dramatic turn for the worse. What had been a critically stable situation suddenly became an acute medical crisis. It started at approximately 2:30 a.m. when the cardiac monitor alarms began going off. Isabella's blood pressure, which had been maintained at 85/50ths mmHg with maximum medications and balloon pump support, suddenly dropped to 60/30ths mmHg. The night nurse, Patricia Coleman, immediately called the on-call cardiac fellow, Dr. Kevin Park, who came to assess the situation. Isabella's heart rhythm had become increasingly irregular, showing frequent dangerous arrhythmias that were compromising her already poor cardiac function. Her heart is failing, Dr. Park told me when he called at 3:15 a.m. Despite maximum support, we can't maintain adequate blood pressure. I think she's dying. I arrived at the hospital at 3:45 a.m. to find Isabella in the most critical condition she had been in since her initial cardiac arrest. Her blood pressure was 55/25 mmHg, despite maximum doses of 4 different cardiac medications and full balloon pump support. Her heart rhythm showed frequent episodes of ventricular tachycardia, a dangerous rapid rhythm that produces little effective circulation. Most alarming, her kidney function had deteriorated rapidly over the past 12 hours. Her urine output had dropped to almost nothing, indicating that her kidneys were shutting down from inadequate blood flow. Her lactate level, a marker of inadequate oxygen delivery to tissues, had risen to dangerous levels. Isabella Thompson was dying. I called Marcus at 4:30 a.m. to inform him that his wife's condition had deteriorated critically and that he should come to the hospital immediately. By 5:15 a.m., Isabella's entire family had gathered in the cardiac intensive care unit for what we all believed would be her final hours. Her heart is finally giving out, I explained to the family. After 4 weeks of fighting against massive damage, it can no longer maintain circulation, even with maximum support. I'm afraid Isabella is dying. Marcus stood at his wife's bedside, holding her hand and speaking quietly to her. Izzy, I know you're tired, he said, tears streaming down his face. If you need to go, it's okay, we'll be all right. At 6:45 a.m., Isabella's heart rhythm deteriorated into ventricular fibrillation, the same chaotic rhythm that had initially caused her cardiac arrest 4 weeks earlier. This time with her heart muscle so severely damaged, the arrhythmia did not respond to electric shocks or medications. We attempted resuscitation for 15 minutes, but it was clear that Isabella's heart could no longer sustain life. At 7:02 a.m. on November 18, 2018, I prepared to pronounce Isabella Thompson dead, and then, at 7:03 a.m., exactly 4 weeks to the minute from her initial collapse, something happened that defied every principle of cardiology I had learned in my 24-year career. Isabella's heart rhythm suddenly converted from ventricular fibrillation to a normal sinus rhythm. Her blood pressure, which had been undetectable during the cardiac arrest, suddenly rose to 120/80 mmHg, completely normal, and higher than it had been at any point during her 4-week hospitalization. Most impossibly, her eyes opened, and she looked directly at her husband Marcus and said, "Why is everyone crying? Did something happen to me?" I stood frozen, staring at Isabella Thompson as she sat up in her hospital bed, completely alert and talking normally to her family. 4 weeks earlier, she had suffered catastrophic cardiac arrest. Minutes ago, I was preparing to pronounce her dead. Now her heart function was completely normal. "Marcus, why do you look so scared?" Isabella asked, confusion evident in her voice. "I feel like I've been sleeping for a very long time." I immediately ordered every cardiac test available. Her echocardiogram showed normal heart function, 65% ejection fraction. The same heart that had been pumping at 10% capacity for 4 weeks was now perfect. Her EKG was textbook normal. Blood tests showed no signs of the massive cardiac damage that had been present just hours before. It was medically impossible. For 6 miraculous hours, Isabella talked with her family, asked about her dance students, and seemed completely herself. She had no memory of the cardiac arrest or her month in the ICU. To her, she had simply fallen asleep in her studio and awakened in the hospital. Then, as suddenly as it began, it ended. At 1:15 p.m., mid-conversation about her upcoming dance recital, Isabella's eyes closed. Her heart rhythm returned to the irregular weak pattern we'd monitored for weeks. Her blood pressure dropped back to critical levels. She never spoke again. Isabella died peacefully 3 days later, on November 21, 2018. Her 6 hours of impossible recovery remain unexplained. Every specialist I consulted was baffled. Her case appears in cardiac journals worldwide, labeled miraculous temporary recovery of unknown etiology. But for me, Isabella's brief return was a gift, allowing her family to say goodbye and proving that consciousness persists in ways we don't understand. I resigned 2 weeks later. Some mysteries are too profound for medicine to explain. Isabella Thompson changed everything I believed about the human heart.